Welcome everybody from the Lynn Room in the Core Market building in the centre of Dublin for today's staff webinar. And at the start of COVID we increased our communication to staff, and it was a very important part of the work that we were doing as part of the broader communication to the public and to our political stakeholders, because staff is our most important stakeholder group, and we had to come up with innovative ways of communicating to you during this very unusual time since January. We come up with new ways such as the weekly CEO's video message and also the new open staff website. So the fact that all of you, many of you are finding new ways of communicating with each other remotely using technology, we've decided to attempt a webinar and getting the three people, and I'll introduce them in a few minutes, or they'll introduce themselves, who have been most centrally involved with dealing with this COVID crisis and the response from the health services to get to talk to you today and to answer some of your questions. This is a sign-up webinar. We've nearly 700 people signed up to this from right across the healthcare environment, from hospital groups, CHOs, Section 38s, Section 39s, and there's a mix of every one of those here today. So the purpose of today's webinar, staff webinar, is pretty much to inform you about what's happened, what has worked well, what has worked not so well, to give insights, particularly personal insights from the three speakers here today, and also to give you the opportunity to ask questions. I'll introduce the panel now, or let them introduce themselves. So Paul, I'm going to start with you.
Just say good afternoon everybody. I'm Paul Reid, CEO of the HSE.
Hi everyone, I'm Anne O'Connor, Chief Operations Officer.
Colm Henry, Chief Clinical Officer.
So the format for today, we're going to have no presentations. I'm going to pose questions to the three panellists, and we'll go through a mix of different subject areas. And also, we've already taken questions from you. We already have over 40 questions that have come in. We'll take questions during the webinar. That question might come into your head based on what somebody says. Clearly, as you can imagine, with 1 hour to do this, we're not going to be able to deal with all questions. We won't get to them all. So we'll get to as many as we can. I might edit some of the longer questions because some of them are quite long in the interest of time. Can I just ask, and it's a question I'll move across from the CEO across to Anne and Colm. Since January, since COVID has arrived to us, what's been the biggest challenge to the health services?
Thanks Paul, and it's a great opportunity to talk to so many staff in all the locations across the country, and we will get the opportunity later to say thanks for what everybody's been doing for us throughout this period. The greatest challenge, I always take it from the public's perspective. And at the start of this, we were always thinking about how do we get the public behind us? How do we get the public to support what we're doing? How do we get the public to act on the messages that we were sending out? And I think when we reflect back over the last few months, it gives me great encouragement, actually, that we did, from the HSE's perspective, we won the trust and confidence of the public during this phase. And that's no small feat. And I do think that challenge was met by the public experience and a much stronger singular voice from the health system. So they heard why it was important what we had to do, they heard what we were asking them to do, and they heard it in a much stronger singular voice. They didn't hear different voices coming from management, from trade unions, from public health officials, from government. They heard a very uniform message. So certainly at the start of this, I was concerned that we do win the trust and confidence of the public very early. And I must say, as I reflect back, I think we've met that challenge very well. And I know it's always fragile, but I think we're in a much better place than we were pre-COVID in terms of having that trust and confidence of the public in the HSE.
Okay, it's something we'll come back to as we go through this. And same question to you. What did you consider to be the biggest challenge, or looking back, what do you now consider to have been the biggest challenge?
I think the biggest challenge probably was that we didn't really know what we were dealing with. So we were trying to I suppose, develop a range of responses at a huge scale that we were trying to develop and implement at a ferocious pace without knowing where the end was. So we didn't know what was going to be happening in even a week's time, 2 weeks' time, 3 weeks' time. So when I think back to the discussions that we had back, particularly say end of February, beginning of March, they were very different. So in March, it was all about hospitals and ICUs, and then the conversation and I suppose the priorities shifted, and we suddenly kind of, had to start doing a lot of things in the community that we hadn't really thought about back in February. So I think it was that. I think it was not knowing the constant, I suppose, moving nature of this, and the learning from a public health perspective. So as we were developing things, the ground was shifting. We were having to change, flex, adapt, do something else. So I think that was it for me.
Okay, and Colin, same question to you.
Similar to Anne, it was like managing a very unstable patient, rapidly changing events and having to respond. And 1 week's priorities weren't the next. And then dealing with a virus about which so little was known and evidence accumulating at a furious pace. So we often think about change management programs such as Sláinte Care over a period of years. This was stuff that had to be done at speed and with knowledge changing not just from week to week but from day to day.
And so from your perspective and staying with you, what's the biggest learning as we're probably 6 months into this?
I think when you look at what worked at speed was not to be afraid to fail. And sometimes in our healthcare system, when we're trying to change things, there's a fear of something not working, and allowing people that space to try something, and knowing that they wouldn't be blamed if it didn't work or if it wasn't needed. It was just go do, and we'll discuss it. If it sounds the right thing to do, we'll do it. Don't wait to find out. Don't wait for certainty, because the virus will just pass us by.
Coming from where you come from that clinical perspective, is that not risky? Do you not open yourself to huge risk in proceeding like that?
Anybody involved in healthcare will know that sometimes you have to manage people who are very unwell without knowing what the diagnosis is. And what you do then is you do the best you can. You resort back to your skills. You rely not just on evidence, which might not be there, but on hunches. And I think it was akin to that, managing a patient that was unstable with an uncertain diagnosis, and reacting at pace.
Did that uncertainty keep you awake at night?
Yes, Frank. Yes, we know much more. The word unprecedented is bandied around a lot, but it's not just an unprecedented crisis, but the pace at which information and evidence has gathered has been unprecedented too. Even looking at vaccine development now, we know we're at a much more advanced stage. Even though I still believe it's a year away or so, we're at a much more advanced stage than we even thought we would be a month ago.
A number of months back, Paul, you said that we get 70% of these things, these big decisions, right, that you'd be happy. Are you happy?
Yeah, I very publicly said that actually to the Oireachtas members when we were talking to them at the time, that they had to bear with us and stick with us, because, as Colm has said, that's the pace that we were operating in this. And the worst thing we could have done is not make decisions. So I am happy that we made decisions as we progressed, and I am happy that we made them as quickly as we could possibly make them. And I think in doing that, if I could just very briefly build on my first point to say, am I happy and satisfied? I think what we've also done in this process is had a stronger coalition, a much wider support for the HSE from government, from ministers, from departments all across all departments. So I think I'm satisfied that we now have actually a much greater credibility across government, and the way in which and the manner in all government departments came in and supported us. I'm much more happier than I was.
Where do you think that came from? So in other words, you don't just open a bag and pull credibility out of that and people start to believe in you. So starting with government, where do you think that came from?
It's a great point. It came from what people experienced, and people experienced our staff showing flexibility, showing agility, showing mobility, showing pace. The public experienced that, and it'll always be measured and tested by what the public experience, not what we ourselves think we experience. So I think that confidence came from that decision making decisions about capacity, making active decisions about building our ICU capacity from our teams very quickly, building COVID response teams in the community. People saw that. They weren't just PowerPoint presentations. they were feet out on the ground, our healthcare workers demonstrating flexibility and agility. So that's where that came from.
So the same question I asked Colm, were you concerned? Did you toss and turn at night about some of the decisions that were taken earlier on, because there were big decisions taken?
Right at the start of this process, I probably, like most healthcare workers, was scared, and that's to be absolutely frank. When we saw what was happening across Europe, it was quite threatening for us. But you know, very quickly when we got a team around together and we gave the system, the services, a little bit of direction, when I saw the pace of which they responded to that, little bit of guidance and unlocking them to make decisions locally, I got great confidence as we went through it. But certainly throughout this period, like everybody who works in the HSE, we did have sleepless nights. We were concerned what we were seeing happening, but we were gaining huge confidence as we progressed.
Just coming to you, Anne, because obviously in that operations role, trying to pull together things that didn't exist pre-COVID, what do you think is the biggest learning as Chief Operations Officer?
I think for me it was, we put a structure in place fairly quickly to, I suppose, enable people to do their jobs. And it became apparent very early on that people were just going to lead teams of people that maybe they hadn't led before. And really, for me, it was about the integration with the system. So how we could link the work that we were doing nationally, because you know we could sit in a room and talk all day, and it might not make any difference at all. But how we could link that with services, and I think for me it was having a structure and a process that wasn't too cumbersome. So we can, you know, we're very good sometimes at creating very heavy process around things, and we stripped all that back. So there really was, as Paul said, it was really about how we could enable people to go and do what we needed them to do. For me, it was just about having a light touch in terms of people heading off, developing initiatives, reporting back in, and working with the system. And I think, you know, that is the only way that we managed to scale so many things up so quickly, just by empowering people to go and do that. We didn't bury people in loads of layers of approvals and administration around everything. And people really responded to that. So I think people felt like they could really contribute and add value. And I personally was blown away by the efforts that people made just to make sure that we could get, you know, something in place here to respond to the needs of the public. So it was really good.
Did you sense any resistance? Because like there are so many sectors right across the healthcare setting. Did you sense any resistance from any sector? Or did you think people kind of realised this is a good way to go, or this is so serious that we need to go this way?
I think people realised, so again, going back to just the scale of this, I think that, you know, one of your earlier questions there about, and Paul touched on the whole confidence piece, I think people looked at the health system for a kind of a bit of a lighthouse really in the middle of this. And I think certainly as a system, we were able to respond to that, and we were able to try and just, I suppose, point to a particular destination in terms of the types of initiatives we knew we needed. But I also think that we were fairly clearly saying at the beginning that we didn't necessarily know all the answers. So there were things that we, you know, if I look back now on things that we've done, we certainly didn't see those at the very beginning of this process.
So let me just drill in. So what if you had to start all over again, which you probably will have to, but if you, with the benefit of hindsight, what would you have done differently? Or give me one thing you'd have done differently.
I think, well, you know, at the time, as I said in the beginning, we started very much with hospitals, and I think that was really important, and the ICU capacity was critical, and we would absolutely do that again. We would, I think, earlier on, obviously, we've developed a lot of learning now about the community sector, about private nursing homes, about the need to support GPs to do what they need to do. And, you know, we got there through the clinical assessment hubs and testing, but I think if we were starting a second, you know, surge, or if this was to continue, we've a lot of learning under our belt now. And I think we would do many of the things that we've done pretty much the same. I'd like to think that we have a kind of a pro forma for some of those things. When we started this, we didn't really know what community testing might look like, or what clinical assessment hubs would be, or, you know, they weren't really on our list at all. So we would certainly build from that. We would look at having a workforce that could move around, and very quickly, I think what challenged us was the absolute prioritization around services. So there were things that we just had to stop, and there were things that actually we needed to continue. And I think that balance between, I suppose, the judgment call over what absolutely has to stop and what we really need to continue is very important. And again, we've learning under our belt now around all of that.
Let's just back to you, Paul, on that same type of question, and let me be specific. Private hospitals deal. We really didn't get much from that, did we? Was that one of your 30% decisions? Is that something you do differently again?
The straight answer to the question is we will do it differently again the next time. We are in discussions and negotiations with private hospital groups again. I won't go back through the drivers of the why we did it that way at the time, but it very quickly became apparently to us that the scale up that we thought might happen in terms of the impact on the hospitals wasn't happening. So certainly the learning for me in that one, and it would be in the 30% category, would be we will do it the next time differently, that it'll be very flexible with the agreement of the private hospitals and agile, something that we can scale up and scale down in one place or in another place at a different time or nationally on the basis of a surge. So we will certainly enter our negotiations the next time to develop a capacity for a potential surge or the capacity for potential peaks and troughs or capacity for localised impacts somewhere. And that certainly is a learning in terms of how we go about it differently.
Is it down to time to consider what you're signing up to, or is it down to, what are the factors that you'd now do it differently?
Well, the factors are how the disease performed. That's very clearly what it is, and how it performed in terms of its impact. If you take specifically in relation to asymptomatic people, which was learning much later on in this disease, not just in Ireland, but in Europe and the ECDC and WHO. So the impact of people who didn't show symptoms, but transmitting the virus very quickly, has been a big learning for us. And that the transmission of disease will tell us differently how we mobilise the next time as well. Again,
we still were a number of weeks behind lots of the other countries, so we could see the progression of the disease. Maybe I'll switch this one over to you, Colm. So a lot of the decisions that we made, we did have 4 weeks on other countries. Mm-hmm. Could we not have learned faster, do you think? Or why was our decision making, some parts of it could have been better when we had 4 weeks?
I think, it's a good point, but I think you have to differentiate learning from other people's experience from the learning from knowledge. So certainly we had the learning from experience, but the experience, every decision is of its time. And the decisions made at that time were based on the experience other countries were having, which was that of overwhelmed healthcare systems, particularly acute hospitals and intensive care units. And we had seen that in Wuhan and obviously in the north of Italy. The learning from knowledge was different. Clearly, the evolving knowledge as it came through, to go back on what we know more now that would be applied to the future, would be, as Paul says, the role of asymptomatic transmission. It's interesting, Dr. Anthony Fauci of the US Allergies and Infectious Disease Institute, he cites that as one of the most extraordinary phenomena in his 40 years of dealing with outbreaks of viruses, is that we're dealing with an almost perfectly transmissible virus where 20 to 40% of people are asymptomatic. And clearly then the evolving knowledge of how that asymptomatic transmission played into vulnerable populations in congregated settings. So of course we did have learning from other people's experience in advance of us experiencing the same thing, but the knowledge was coming through in real time to all healthcare systems at the same time.
So we spoke about private hospitals, the City West self-isolation and the care facility. Is that something you'd have done differently, Anne?
I don't think we could have. So again, going back to where we were when we made these decisions in February, and we've got to remember that I think we'll all remember the day when we looked at a whiteboard in Dr. Stevens where the modelling was being put up for us, and we were looking at figures that told us we would have potentially 1,200 people in ICU on the 12th of April. That's where we were coming from. And I think, it's easy now to look back with the benefit of hindsight, but I think back in March, we just didn't know, and we knew we had to have some facility. Now, City West provided a really good service to people. It was very big. I think the learning might be that you wouldn't go for one really big place because actually, we just didn't use the full capacity there. And I think that, we kind of realised also fairly quickly that we needed different types of isolation. So, for example, in Dublin City Centre, we had isolation for Roma communities and that. So I think that the, City West we describe a bit as an insurance policy, really. The self-isolation facility was used, it was run really well, and we developed really good pathways for people who were COVID positive or suspected positive. We had all sorts of people go through there. City West is still being used for healthcare workers. The care facility was never opened. That was, at the time, being described as a field hospital, a real overflow facility. But at that same time, we were setting up temporary mortuaries around Dublin City. So, we were talking about a different experience, and thankfully we didn't need it. So in a way, it's a sign of the success of the system that we never actually needed to open that facility.
Do you think people acknowledge that exactly that point? That,
No.
So we did develop a big mortuary, and we got some criticism that it was never used, which is ironic really. But do you think the point that you make, that's acknowledged by some of the political system, some of the media, some of the public commentators?
I think, in one way I'd say it doesn't really matter. I think that we have a lot of people looking at the cost. Now, we have spent a lot of money since February and March in relation to COVID. I think I would be much happier knowing that we did that than having had to face into a scenario where we hadn't done it and where we needed it. So we did develop a bit of I suppose, an approach, and, you could argue, we didn't need all the ventilators in the end either, but, we would have been rightly stuck if we did need them and we didn't have them. So there was something about the position of, we felt it was better for some of those things to be looking at it instead of for it, so at least it was there. And as I said, we were describing City West and the care facility in particular as a bit of an insurance policy. And I'm very glad we did it. We couldn't have not done that, whether we'd have done such a big one as a once-off or not. But again, we were looking at a completely different scenario, and the self-isolation facility was used.
Just been Paul in on that same point.
Yeah, I can just make one brief point just about learning, and Colm prompted me just about experience. I think one thing I certainly have reflected on is the role that our public health teams played and will play looking forward, because public health teams weren't always that visible across the health system prior to major outbreaks and infectious diseases. But I think the role that they played here has been very integral for us. And I think probably a learning for me is, as we look forward, is we do use them in an integrated way. I mean, we convened our National Crisis Management team on the 27th of January. I think we convened it on the Sunday, met on the Monday. And we were taking our knowledge from the public health teams. But I think as we progressed, they were integral, working with our community teams, working with our acute teams, going into nursing homes, going into meat plants, giving us knowledge. So a very integrated way, leveraging the fantastic knowledge of our public health teams, is one we'll do stronger.
Colm, you're trying to come in there.
Yeah, I think I was just on that point. I think it's that learning from experience of other countries on our own, and unfortunately that the penny doesn't seem to have dropped right across the world, is if your line of defence is on building ventilators, buying ventilators and ITU beds, and if it's that deep, then you're not going to win. And I would add to the tribute to pay to public health, because if you remember, Catherine Motherway of the ITU Society came out early on, as did other members of the ITU community, and they worked heroically through when we peaked at over 600 cases. But they consistently said, yes, we will build up, we'll adapt at speed, we'll provide greater resources, but really if public health lead on this, which they have, and if people listen to what public health say, then you will have less patients coming under our care. So the biggest single learning, not just for Ireland Inc., but for the whole of the world that's facing this, is a stronger and more robust that your public health line of defence is, then the lines of defence behind it will be all the more enabled.
I'm sure every public health staff member on this today will say hurrah to that, and rightly so. Back to you, Paul. What's the singular thing you've been most proud of since this all kicked off?
I'll relay a very brief story. During all of this, as you know, we were all drawn into various media communications, and I remember just a few weeks ago actually doing a News of One interview. I think it was Anya Lawler. And just at the end of the interview, she said to me, thanks for coming along, and we are all very proud of the HSE. And I walked away from that thinking that was a really strong statement that she made. It's not something we've heard too often in the past. So, what's made me proud is that the public have got a greater, respect, a greater confidence, greater trust in the HSE. Now, I know that's fragile. I know as we head into winter, it's going to be severely challenged, but builds us from a much better base. And again, as I said at the very start, that doesn't just happen. That happens by what people see and experience from our staff, all our staff, whether it's admin, catering, frontline staff. They've built a trust in the HSE, and I'm very proud of that.
So David Whelan has a question sent in since this has started. If a second wave comes, are we ready, Ms. O'Connor?
We're getting ready. I think we actually, as it happens, just in the last 2 weeks, we've been reviewing a lot of what we've done. So in terms of the operations hub that you mentioned there a minute ago, we've actually been looking at all of the different work streams and saying, well, what's the real takeaway now for a second surge, be it to do with COVID or even in terms of a winter surge related to flu or anything else. I think, we have a way of working that we've established. A lot of that we're holding on to in terms of just being able to make decisions and implement initiatives quickly. We are challenged on capacity, so we're obviously now, resuming service delivery in many areas, and the volume of activity is going up. So a lot of our staff who may have been deployed into COVID-specific initiatives are going back to do what they did before. But I think for us, we have, we know a lot more now. And we have that critical experience of knowing some of the steps we'd have to take. So I think from that perspective, we're much better equipped. I think there's a flip side to that in that people are tired. So in terms of being ready, I think people have really gone way over and above in terms of what anyone could ever ask of them, and they're tired. So we're heading in now to the autumn with a lot of tired people, which maybe we didn't have, even though we had come from winter into COVID as well. So I think we need to just ensure that we have, a level of resilience built into our system, and that staff feel that they can continue to work and feel supported. I also think, though, that we are challenged on capacity. So in terms of readiness, we are looking at what capacity we have. We're looking at what the deficits are and how we can plan to actually build that capacity over the coming weeks and months.
So 2 things, keep this short. 2 things you retain from what we've done, new things over the last 6 months that you'd retain going into winter.
I think we absolutely will retain the COVID response teams in the community. So we had set those up in response to the nursing homes. We're looking at those in terms of how they need to be enhanced to support nursing homes. And
why would you retain those? What's so
special
that you've singled out CRTs?
The CRTs have been invaluable to us and to, I suppose, everybody in terms of the support that they have given to nursing homes in the area. Pre-COVID, we had a different relationship with private nursing homes. I think we all know that we can't go back to that. And I think the level of knowledge that they have built up in local areas in relation to nursing homes is really valuable to us. And we need to build on that. We need to ensure that we have sufficient specialist support available to nursing homes and to older people living in communities as well. We are approaching, or we're moving towards a model of community health networks, a lot of work around integrated care teams and that. So the CRTs will be critical to us in terms of supporting nursing home sectors. That's one. The second one, I think, would be in terms of, well, obviously, testing, community testing is here to stay. And we will be retaining testing.
Come back to that specifically.
Yeah. And I think the third thing would be in terms of just how we can work in an integrated way between the national and local systems in terms of empowering services.
Okay. Colm, question for you, and it's a thing we discussed over a cup of coffee before we came in, and it's in that space. Are we ready? David's question. Australia, and what's happening in Australia as they go into winter?
Yeah, it's worrying. It is their winter, and what we see there now is one of the lessons of what happens during winter is people's behaviours change. They migrate indoors more. There's more congregation in closed settings, and perhaps there was an easing of the social restrictions there. Now, the great majority of cases in what's been a sudden surge there have been in the Melbourne area, so it's not consistent across the whole country. The lesson there, if there is to draw, a bit like we learned from their flu experience in advance of our own, is that the winter will bring behavioural changes that foster growth of the virus once it's seeded in the community. So the best thing we can do in Ireland is to obliterate as much as we can community transmission in advance of the winter, and then carry through those behaviours which are tough, which minimising the number of contacts, avoiding closed settings, and avoiding congregated settings at all costs, along with those other basic measures. So people talk, and it's understandable that they would ask what the HSE is doing about winter and our plans, but I think all of us here would say that our plans will only be as good as the responsibilities and the actions of every individual out there in Ireland.
So you have 700 staff here looking at you today. What would you urge 700 staff to do?
Well, they're not just staff; they're citizens. So as citizens, which I know that they're very familiar with those that basic advice that we give to all our citizens on hygiene, on distancing, but in addition, they have a particular responsibility, as they well know, to work that in healthcare settings, particularly in those where there's congregate settings of older people, that there's particular risks of transmission of the virus. So it's a heavy responsibility for us to bear while providing care at the same time. But they've been exemplary in their behaviour to date. There's no doubt about that. And it's only but for the behaviour and compliance of our staff, things would have been much worse.
Is there anything in the clinical space, and very brief answer on this, is there anything, same question that I posed to Anne, that you would take learning from COVID into, let's say, winter?
I think the biggest thing for speaking as a geriatrician that I still am is that we see that a model of care for older people, which you've developed in this country over 20 or so years, and that of people, and more recently with the Fair Deal scheme, it's not something that's friendly to a pandemic era. So we've been doing a lot of brainstorming over this over the past few weeks over what elements of the work that Anne led on in operations can be kept on, and what elements of the National Service Plan, those things we're piloting through ICPOP and chronic disease management, where we can ramp up. And one of the big areas of focus will be, of course, on older people and supporting them at home. Because there's an additional reason why older people would not want to enter long-term care now, and that's because it's not a pandemic-friendly setting. Even with and if it is to be as pandemic-ready as possible, it makes life more difficult due to the isolation and limited number of visitors. So I hope there's something we can keep on, not just in the HSE but in wider policy terms, that we will really foster conditions to keep people safe in their own homes for as long as possible.
And so one of the questions that came in was specifically in that area, and one of you might answer it, can we expect an increase in the home support budget? So Paul, will I give that one to you?
Yes, happy to take it. We have entered very early dialogue with the new minister, obviously, and the government, Taoiseach. And what we've been saying this morning in our own media conference is we know that our winter plan this year has to be extremely and very different than any winter plan we've put in the past, because some of the conditions and some of the experiences that we've seen in previous winters just won't be tolerable based on public health issues. So I think there's a strong recognition from government, and that gets back to my first point here today, a stronger confidence in government and the HSE, and I think there's a realisation that the investment now needs to go in, not just into the acute hospital system, but the way of us avoiding a congestion in our hospital system is to invest into our community services. And that will be a combination of home supports, increased home supports, improved working with our GPs, who played a phenomenal role during this process, COVID response teams, multidisciplinary teams, keeping people out of the hospitals. And that's going to require an incremental investment in our community services.
So a question has just come in here in that vein. Do you think COVID will accelerate the evolution of virtual health across a whole range of areas? And the question specifically spoke about child and adult mental health. Maybe I'll put that one to you, Anne.
Yeah, and before you come to that one, Paul, can I just make one comment just to touch up what Colm said, just and to get it out early, I guess, in terms of the question about what would we be asking people to do. Obviously, we're going to be approaching staff flu vaccination season, so we'd absolutely be asking all staff to be vaccinated this year. It's a really, really important thing for our patients and for ourselves. So maybe just to say that. In terms of the virtual health, we've seen a very significant uptake of virtual health in some areas. We're in the process of rolling out Attend Anywhere as our national platform for virtual health, and we know that already in terms of outpatients, we have approximately 80,000 consultations a month now in terms of OPD. We also have been using other platforms in terms of mental health, and in CAMHS in particular, we have had a significant focus on virtual health for some time that has now come to fruition. And I think,
COVID on the past, though. The virtual GPs, particularly, my recollection was that there was a certain resistance.
There was a resistance, and there was also a resistance in mental health. And I say that as someone who's been around it for a while, in terms of just the perception that the therapeutic relationship could be impacted negatively by virtual health. However, we have now seen that, in fact, it can be very positive. And speaking to one of our ECDs, who is a CAMHS consultant herself, she would say that, I think about 80% of their consultations during COVID were virtual. And in fact, from a CAMHS perspective, it was extremely positive, because actually having a consultation with a young person from their home could be extremely beneficial. So I think it is something that we are going to be continuing to work on, to scale up and to roll out nationally.
So, and again, sort of lots and lots of questions coming in, similar questions, and one of those is around service restoration. Paul, back to you. Our staff members complaining that there isn't a clear direction or a clear roadmap in terms of service restoration. What would you say? Would you agree with that?
This has been a very difficult process for us. How do you get back to services in a very safe way? So back in June, we launched a framework approach about how we would approach restoring services. And we've just come this morning, Colm and myself have just come from a media briefing where today we've launched a roadmap for delivering services safely, the restoration of services over 3 phases between now and February.
That's on HSE.ie.
And that's on our HSE.ie site. And people can look and browse through that. But the reality of it is, for people who are using our services, and we've been very clear on this morning, we're urging the public to bear with us, because we have to protect the public. We have to have strong infection prevention and control measures. We have to have social distancing. Activities will be slower, and we're urging our public to give our staff and our healthcare professionals space in delivering that. But it will be, if anybody's gone for a haircut or used retail shops lately, it's a very different experience than it was in the past. So it will be a very different experience as people come into our services, whether that's in the primary care centres, our social care services, or our hospitals. It will be a different experience, but we're doing it because we have to protect the public and we have to protect our staff.
So waiting lists wouldn't have been great pre-COVID. Do you think we'll catch up? Is that your expectation, that we will eventually catch up, or is it just going to exacerbate?
Yeah, well, if you take some of the services which we've already, and just to remind everybody again, on our teams on the webinar today will know this, not all of our services have stopped. Some of them are back well before now. They weren't waiting on today. But in particular, if you take our screening services, we launched the restart of those back in early July. And that is prioritising, particularly in cervical check, prioritising the people who need to come back earlier. And that backlog that has been built up will be completed by October. So different services will begin to catch up on the backlog created during COVID. But we won't immediately catch up on all of the backlog of elective care that we have. It is where we see the private hospital agreement for the future as part of our solution.
In that same vein, Colm, cancer services, it's another question has just come in there, a number of questions. Can you speak specifically about cancer services and cancer services generally, and then about screening specifically?
Well, if you look at, there was an interesting paper Anne brought my attention to this morning from the Lancet, and what they did was they looked at pathways to cancer. So in recent years what's happened, people have earlier access to cancer pathways, and hence outcomes are better. And those pathways are through screening, which is a population basis, people know, where we bring people in off the streets who are healthy, and through early diagnosis access pathways through rapid access clinics. If we don't have those sieves earlier on, people will present later with cancer. This modelling work in the Lancet paper showed that fairly predictably that unfortunately there will be excess mortality in cancer and 4 cancers they identified as a result of later presentation in COVID. And there's 2 things, people have focused understandably in this country on screening. What probably worried us even more than that was the fall off in presentation to rapid access clinics. And these clinics fell by over 50% in some cases. These are clinics specifically designed to pick up people who've got early symptoms and signs of cancer.
Why do you think that is?
I think it was fear.
Fear of what?
Fear of coming to hospital, fear of COVID, maybe confusion that the services were stopped or curtailed in some way. We took great care throughout the pandemic, even though we were swept along in many ways by events and by the focus on COVID, to remind people that these services were still running. In addition, the traditional referral pathway was through GPs, and people also stopped attending general practice.
Is that a failure of us, the services, in terms of reassuring people that they should turn up? Or I suppose my second question is, how do we avoid this as we go forward?
I think it's glib to characterise it as failure, because it's something that happened in the middle of a pandemic, of a once-in-a-lifetime pandemic crisis, that people stopped coming to hospitals and healthcare settings. How do we prevent it in the future is we provide a healthy, or a safe environment for people to come to for screening. We assure them that we're re-establishing these screening services, or these rapid access clinics are being provided in an environment that's safe, where we're minimising the risk of contracting COVID. And we also remind them that the importance of presenting early with these symptoms, because earlier diagnosis means less treatment and better outcomes.
One question came in, and I can't think of pass without asking you. Somebody came in asking about OT services.
Oh.
And when will one-to-one OT services resume? Fast answer, please.
I think they'll resume when it is safe to do so, is the short answer. So we know that urgent service, and I think the question there relates to the fact that urgent services have continued. OT services in the community will be reintroduced in line with the guidance from Public Health and our roadmap. So it's hard to say when, but everything is starting to come back. We can see an increase in activity in OT in the data that's coming in from June. So we know it is ramping up, but it's got to be safe.
One of the general themes that has come in is around exhaustion. Staff were tired. I'll put this one to you, Paul, and a question that came in yesterday. How can we help staff who are exhausted at this stage, having come from winter into COVID and going back into winter, and everything Colm has said about Australia and the experiences there? What can we do to support staff, to help staff?
I think it's a combination of factors. First of all, I want to recognise it because I've met a lot of staff who have been working relentlessly basically since January, and as you said, prior to that, prior to winter. A few things we have been strongly encouraging at a local level. Local managers make decisions to ensure that people do get a break, take their annual leave now, because although a lot of our commentary is about the risk of a second surge, now and over the last couple of weeks and over the next few weeks is a really important time, including ourselves, to take break, take a time out. Second one will be a lot of our local systems are putting in a lot of flexible arrangements for staff to accommodate various needs and to ensure that we're getting a break for people as well. And thirdly, we have and will continue to recruit some extra staff all across the country. In total, we've put about 3,500 people on the payroll that weren't previously on it pre-COVID. And that's an important part of our process during winter. It'll be an important part of our winter plan as well. So my strong message to everyone across the system, and particularly to local managers, is people need to take their holidays, need to take a break, work flexible arrangements around it, because we will need everybody. I said this morning at a press conference, we've never said this was a short game. This is a long game, unfortunately. And, who knows, are we at half time, or who knows, are we three quarters of the way through? But we need our resilience of our staff.
Okay. And I think those are very important sentiments to pass on to everybody listening here today. So I'm going to come into a kind of a rapid fire round here, because a lot of these are questions that have come in, and as I said, some of them are probably things that we can answer here, probably can't answer here. So annual leave, Anne, to you, staff who were obliged to stay at home, mind their kids or other reasons during lockdown, will they get their annual leave back?
I suppose what I would say is that there have been a lot of arrangements put in place across services between local managers and staff in terms of facilitating childcare or other carer arrangements over the last few months. The reality is we are a public sector, we work in a public sector environment that's bigger than just health. So I think that is something in terms of time, that is something that really needs to be discussed with local managers. We can't say uniformly that everybody's going to get extra annual leave. That's not within our gift. But we certainly have sought to work and to support staff as much as we can with their specific arrangements. So I think for anybody who feels that they have specific issues, they do need to take that up with their own line management.
Second one, leave it with you, Anne. Working over 4 days in the interest of facilitating physical distancing.
I think, again, at the risk of sounding like I'm trying to get out of it, that is something that has to be discussed locally. So all local working arrangements have to meet the needs of the services. And I think, first and foremost, we are here to provide a health service, and clearly we need staff to be available to do that. So depending on the role, the person, the arrangement that's there, the size of the team, etc., that's something that can be negotiated locally. But the priority for us now more than ever really is to continue to meet the health needs of the population. So that has to be the priority. But I would suggest again that people need to discuss that with their local line managers in the first instance.
Okay. Staff working beyond their normal grades, in other words, as the person put the question, people working outside the boundaries of their grades. Question is, will they be enabled to work to their full potential and use their skills post-COVID?
Can I take that briefly, Paul, because Anne is close to some of it, but just, I think that's a lesson for us at very senior level. We all touched on it earlier on. How do you unlock the system to just go and do and be flexible? And I think people have found great encouragement by working beyond, as you describe it, beyond their grade. But I think people have found great motivation and great inspiration from them by having that flexibility. So I think that learning is back to us. What did we learn as a senior team that unlocked the system better to have that flexibility, have that innovation, have that pace, have that speed? And that's a real learning that we are going to take from this, that we are taking from it. How do we give direction from the centre, very simply, and letting the system do, as opposed to relentlessly having the system reporting up to us? And that's something I take quite serious.
Is it achievable?
Big learning. I think so.
What you've seen over the last 6 months?
What I've seen over the last 6 months demonstrates how powerful it is when you crack it. And that's something for us. It's something for the department. It's something for the whole government to think about how we unlock our systems, take the bureaucracy off them. And I've said that publicly as well. We need to reduce the bureaucracy in the system, increase the innovation, increase the flexibility. Now that's a challenge, big challenge, but it is a challenge back to senior.
Trust as well, as in trust in our staff.
Increase the trust in our staff, and then the outcome is increased trust in the health system. You know, so it's
back to your trust and confidence.
Yeah, it all feeds each other, but it's a challenging one. But I think that's more a challenge for the senior leadership than it is for people who work in the services.
Okay, so my next one is about remote working. Again, these are not my questions. These are coming in from our staff. So will remote working be encouraged, as in working from home / remote working be encouraged? Staff whose roles can be delivered remotely for the foreseeable future.
Yes, I mean, again, come back to my earlier point, you know, we're here to provide services, and certainly remote working where it is possible, where it doesn't take away. Obviously, we have to be guided by public health all the time in terms of how we work, how we, you know, look after our own staff, let alone the public. And I think we would certainly be seeking to facilitate it. However, we also need to provide the service. So I think there's a balance there, and I would, based on the discussions we've had so far, I think we are heading towards a hybrid model where people will be, you know, working remotely some of the time, and then coming into work. And certainly I know that colleagues in the States are currently looking at all buildings to see how people work. There are some roles that lend themselves more to remote working than others, but I think that we are looking to see how staff can safely continue to work or return to work. Remote working doesn't work for everybody. Some people find it very difficult.
Yeah, I think let's state the facts first of all. It is government policy, it is public health policy that people, where possible, should work from home. That's the, as Anne said, we're providing a big health service, so we have to find that balance where people don't need to come into buildings, central buildings, and can be facilitating work from home. We'll do it, but we are running a massive public service, so we need people running those services. So it's not a homogenous answer, unfortunately, for everybody, but we do need people who are delivering those services to the public, delivering them, and where possible, avoid people coming into buildings and congregated offices, etc.
Clinically, Colm, that same point, because we've had a flood of questions on this. From a clinical perspective?
Well, look, healthcare, people don't enter healthcare with the idea that they're going to be dealing with patients remotely for the rest of their lives. So much of healthcare doesn't lend itself to remote healthcare, to be frank, but there are elements of it that can. And actually, it's argued that some elements of healthcare, the traditional elements such as outpatients, are not really as productive and as efficient as they should be. So I think it's highly context dependent. There are times, as everybody knows, when a direct contact with the patients is not only desirable but essential. There are other elements of healthcare, particularly routine outpatients follow-up, where you're looking at particular metrics or elements of the patient's care that don't demand direct contact, and it's those elements that have been exploited. And I note that the programme focusing on St James Neurology and the work of Colin Doherty, and of course in our own experience, where I think upwards of 80,000 virtual consultations were carried out during the month of April by necessity, as much as by innovation driven by necessity. So we can't, while it's important to promote this, nothing will escape the fact that people enter healthcare and as a profession, and people come to healthcare as patients with certain needs, many of which demand immediate contact with the patient.
Okay. Comment here, as a thing from a question, I'll come back to the questions. This is an extremely positive engagement. Well done to Paul, Anne and Colm and others for their leadership so far through COVID-19. So I'm sure we'd all say thank you for that comment. Staff safety. Paul, one to you, and it's in the context of PPE and keeping our staff safe. It's clearly foremost to your mind since the start of this. Could you expand on that?
Yeah, well, actually, pre-COVID, we did a lot of work around our corporate risk register with the new board, and one of our highest risks was around maintaining staff safety and the initiatives that we need to put in place for it. So it's always been on our radar. Obviously, for COVID, it's been extremely top of our agenda in terms of protection. Just on PPE, if I can make a few brief points on it, there was a very challenging period between February and March, and that's where we had to mobilise across the world. And I think so it's one thing that demonstrated Ireland, I know it's easily said, punched way above its weight, but our ambassadors, whole of government approach around it, IDA Ireland, played a huge role in getting us a supply of PPE in Ireland. Part of that now for the next phase, just to briefly mention, is that we want to build up the capacity of the Irish Indigenous industry to supply PPE, and we are making really good progress on that. And finally, can I just say briefly, as you have asked the question, unfortunately throughout this period, we have lost a number of healthcare workers, unfortunately just overnight, another one as well, which is a total of 8 healthcare workers working across the system in healthcare overall, and that's really very sad, and that's everything that's at the top of our mind. You asked us earlier on what might keep us awake during this process, and that certainly is one that has kept all of us awake, that we protect our staff.
Okay, thanks for that.
And sorry, can I just say on the recent
sure.
passing, obviously again, pass my condolences to the family, and I would ask everybody to respect that it's very early. The passing was just last night, and obviously we want to go through the right protocols and contacting families, etc.
Sure. Another question in here, which is an interesting question, quite a long one, so I won't go through it, but Anne, I'm going to give this one to you and maybe pass it to Colm. So it's staff who've been redeployed. This person makes a statement or a comment that redeployed staff may have been desensitized to COVID, may have lost the care and compassion that we would ordinarily display. What would you say to that?
So I think there's a couple of things in there. So staff who've been redeployed from their core roles, I'm taking is what that is implying. I think, desensitization is something that we have to think about all the time, and certainly in healthcare, empathy is really important and underpins that compassion and empathy underpins a lot of what we do. So I think, certainly for me, when I hear about desensitization and that, I worry about things like burnout, for example. And I think it's really important that people look after themselves during this time. I made a point earlier that I think now more than ever, particularly as there seems to be less pressure than we've had in the last few months, people have time to reflect and think about what they've been through. And I think that can, often cause people to maybe feel worse now than they did when they were fighting the good fight back in April and May. So just, I think for us in terms of staff who are, I'm not too sure about the redeployment bit, I think all staff need to be careful and to mind themselves and to talk to colleagues, because I think everybody's probably feeling in a similar way. Anybody who's been very involved. There is an issue also for people who haven't been in the centre and haven't experienced the same, I'm going to use the word battle, but I do think there's something about an energy that comes from being in the thick of it, and I think there's a risk there too, because everybody needs to just step away and refresh themselves. But certainly anybody who feels desensitised, anybody who feels like they are, I suppose, emotionally drained for any reason as part of this needs to really talk to people and to seek supports and to look up our yourmentalhealth.ie website if necessary, where there's a lot of support and information available to people.
Some of the representative bodies would have said that the supports aren't good enough for members.
And I think that there are different things within that. So we've done a lot of work. We have a psychosocial work stream, and that's intended purpose was to support service users, the public and staff. The yourmentalhealth.ie website was updated, and a lot of work went into that to provide information and tools to everybody, the general public and staff. There's also online access to, I suppose, psychological supports. So, for example, Silver Cloud was made available to all staff and to the public as well. So I think that there are different supports available to people. I know that there's concern about access, for example, to one-to-one counselling. Within the HSE, we have a very good employee assistance programme. People are able to access supports through occupational health, etc. However, as members of the public, all of us, we also have access to lots of other things. And I would suggest that people access the yourmentalhealth.ie website.
Would you consider increasing the one-to-one supports as a learning from and a listening to the representative bodies?
Yeah, so I think in terms of the HSE directly provided services, our occupational health physicians are involved with the psychosocial framework that we're developing. That is near finalisation in terms of the supports that are required. We're working with HR on that. I am conscious, though, that in the broader health sector, it's not necessarily, again, a homogenous view. We have Section 39s, we have other agencies in the health sector that might not have the same level of employee assistance. So we are taking all of that into account. So it is something we are looking at.
Paul, you've said in the past about the 2-metre advice that had pretty much come through from the start from WHO, that would cause significant problems for us going forward. You still hold that view?
Yeah, so look, I think the reality of it is, and Colm has done some work with his teams on this, we obviously want to protect staff, we want to protect the public. We've looked at it from 2 or 3 perspectives. Colm has led a process from our own infectious control, prevention control teams, from our public health teams, and from the colleges and knowledge that's in there. And all of the evidence and recommendations coming back to us is with certain mitigations put in place. A, our healthcare, we are healthcare workers, our teams are, and B, the PPE that's deployed there. It most likely won't be 2 metres, and that's a reality for us to where we will have to. But Colm has finalised a report for me. Will make the recommendation to me, but that's most likely the way we're heading. The impact of 2 metres is just impossible and unimplementable for the health service. But I think we will find a way forward that's very pragmatic.
Straight to the well. Colm.
Yeah, so if you look at the infection prevention control advice given for droplet illness or droplet-borne transmission, it generally is of the order of 1 metre, and clearly the further you are away, the safer it is. But the added benefit from 1 to 2 metres, the considered advice we're getting from experts is there's not a huge additional benefit. But what we found is, and I suppose one of the reasons for our earlier press conference was restoration of services, that there are counter risks emerging. We talked about cancer services earlier on in this webinar. We've talked about screening services, and likewise we have to look at the counter risks that are emerging as a result of our response to COVID-19. And one of these is reduced throughput, reduced capacity of our services, and we need to retain surge capacity. We need to restore services to some semblance of normality insofar as it's a new COVID normality. But the impact of rigid adherence to a 2-metre distancing would have a profound effect on our capacity and would create additional risks that are perhaps as great, if not greater, than COVID. And so what we need to do is look at the best expert advice, and we're very fortunate that Martin Cormack and his team, we've spoken to the colleges, Royal Anaesthetist, RCPI, RCSI, the GP community too, and obviously the public health community who are leading in this. And from that advice, we will come out with a clear guidance for our healthcare system, for our workers, which balances safety and also balances the need for us to deliver services for people, not just for COVID-related illness, but for non-COVID-related illness, which is accumulating as we speak.
Okay. And my very last question then, and it's from Catherine Healy, who's put in a couple of questions. Paul, very briefly, she's asking, did COVID highlight that fundamental split between public and private, that two-tier system?
Yeah, very briefly, I think what's the reality is there's two very different health systems. There's one health system like our public health system, which has a very large waiting list, and there's a private health system that doesn't have a waiting list. That's the reality of experience of public health in Ireland. And what's interesting during COVID is people who did have private insurance and didn't feel that they had that ready access very quickly got up in arms about it. So my judgment on it is there will always be room for private health insurance and delivery of healthcare, but it has to be more integrated with a public system. That's my view.
Okay, so in the time that we have, and I'm sure people are bursting to get back to work, I want to ask you just to give a few closing comments to our staff, about 700 who took time to tune in today.
In fact, I made a really profound comment there, which was just about vaccination. As we head into the winter again, we're all apprehensive, we're all a bit scared. And as there are 700 people here, hopefully go away as ambassadors. Last year we had about 65% take up nationally on vaccination for flu, but in some places it's as low as 20%. Some countries make that mandatory, it isn't here. So we really should be only dealing with margins of exceptions of staff, so encouraging people on that. My final closing messages are what I've said at the start. I'm in this role just over a year. I've never been as proud to be in a role, and I've never been as proud to be working on the HSE. I think what the public have experienced has been phenomenal. There's learnings for all of us in it. I want to thank all the staff for the flexibility, the agility, the resilience that they've put in over the last few months. And I know they're feeling tired and we want to support and take a break. But I'll urge them to stay with us because this is a longer game, unfortunately. To stick with us, but what you've done has put the HSE on a very different map by any measure of public trust and confidence.
Okay, so I'll step out front again and just to say thank you all for taking time for coming in and listening, and I hope you found it useful. I hope you found it informative. I hope we've answered as many of your questions as possible. I think that's one of the main purposes of this. Obviously, we didn't get to everybody, and apologies for those who we didn't get to. So, from Paul, Anne, and Colm, and our Irish Sign Language interpreters, as usual, thank you very much. And hopefully, we'll do another one of these again. We'd like to get feedback from you as to how you found this. So if you go back to the same email address and give us your feedback. And we'll certainly, as we have been doing right through COVID, trying to improve everything we do, we'll do the same on this one. So thank you very much, and we'll chat to you very soon.
Thank you.
Thank you.